Good afternoon, everyone. This is Laura Conley. I'm the Director of the California Department of Aging. And for those of you just coming into the door and previously come through the door here and are participating on the phone, I would like to welcome you to CBA, either in person or virtually, depending on where you are, and to our second CBAS Stakeholder meeting. The first was by webinar. But today we have about 25 or so people here at the department, and I have heard that we have about 300 on the phone participating. So I'd just like to thank all of you, whether you came in person or on the phone, for participating with us today. I know you've taken time out of your busy schedule to be here with us, and we really appreciate your involvement and your input in this meeting and the series of meetings that we will have going on over the next several months. I am going to go to full agenda.
Welcome to GoToWebinar. Webinars may be busy. Please enter your access code followed by the pound or hash sign.
Is this a significant message that we're getting from GoToWebinar? Perhaps yes or perhaps not. I will just say, and I think for those of you who participated on the first webinar for this group, we have an ambitious agenda for the next several months in that we need to have a waiver amendment to CMS by May of this coming year, May 2014. So we know that CBAS is a program that has gone through a lot of evolution in the last year and will continue to do so way beyond this waiver amendment. But our focus for this work group is really the specific items and issues that we need to develop consensus and closure on in terms of developing the CMS waiver application. And know that we will continue to have many additional discussions as the program continues to evolve, as new models are being developed and tested moving forward. But I know that with Bobby as moderator and the work group that's been putting this together, our focus is really on those dealing with those core issues that we need to address before May to meet our commitments in terms of maintaining this program and CMS Medicaid payment for the program moving forward. So I will be participating as a out in the chair, and thank you and wish you all the best. And please, we benefit from all of your input, whether you're here in person or on the phone. Bobby will lead us through the protocols, I think, in terms of this joint participation virtually or in person, and look forward to a good dialogue in the meeting. Thank you.
Bobby Wunsch, and I'd like to welcome everyone to the meeting today, both, as Laura said, here at CBA, but also many people on the telephone. Before we begin, we're going to do a little bit of housekeeping for those people in the room and for those people on the telephone. So I'm going to introduce you to Denise Teach from the California Department of Aging.
Thanks, Bobby. And really quick, we just want to say for the people who are in the room, first of all, we're doing our best not to have any technical difficulties. Things are always a challenge, but you can help us by turning off your cell phones or putting them into a airplane mode, because they do interfere with our equipment. And like I said, we're doing our best to minimize any of the sound issues. And once we're done right up here with this mic, we're gonna I can put it somewhere where it doesn't do the popping and whatnot. But again, keeping things sensitive so that everybody can hear. If you are out there joining us by web, feel free to send us a note. You can type a note, raise your hand, and type a note into the type box, and tell us if you're having difficulties with hearing, and we'll do our best to resolve things as we go. For the people in the room, also, if you need to pick up and leave for some reason, and you need to go out in the hall, there are a couple of badges over in the corner. You can grab those and use them to get back in if the door is secure. So if you can use the restroom or step out for a moment, right there, and it's showing you where the badges are. Also, there's some copies of slides for those of you who didn't bring them and need a copy. They're over in the corner where Ed is standing. There are a few copies over there. We want you to use caution when using the caution tapes, because we have a bunch of paper tape around here for all of the phone lines and whatnot. And other than that, I think we're pretty good to go. Those who are on the phone are in the listen-only mode, and we will be taking your comments and feedback during the public comment time at the end of the meeting, or toward the end of the day. And Bobby will direct us to that. I just want to remind everybody in the room that we'd like all of the members of the work group who are sitting at the table to speak as loudly as possible so that everyone on the telephone can hear. We have mics around the room, but every single person doesn't have a mic. So in order for the work group members that are on the telephone, who will also be participating in the meeting, to hear, and for the public on the phone to hear, it's important to project. And I want to do a check-in and see if our work group members on the telephone can speak to us. So Dr. Henning, Bill, are you on the phone? The test. I know a few people are calling in. Okay, Bill Henning, are you on the telephone and can you speak to us? And if you're trying to speak to us, would you type in a chat so we can see if you can? Okay. Oh, okay. Bill, you have to unmute your phone or your computer. So all of the members of the work group who are on the telephone, we're just trying to attempt to see if we can hear you. Bill, can you unmute your computer? Probably.
My computer and my phone are now unmuted. Can you hear me?
We can hear you barely. So I'm going to bring the microphone over to the telephone so that we can hear the members, we hope. Bill, will you just say hello to everyone again?
Hello again. This is Bill Henning.
Awesome. Great. Okay. Lucky I knew him. Okay. Now, official welcome. Thanks, everybody, for being here. We're going to get to work. As Laura Conley said, this is the beginning of the next phase of the life cycle of the CBAS program. It's an extremely important phase, and we need everybody around the table, figuratively and really. We need all of your expertise to get through this next phase. We have an ambitious agenda with our 4 meetings that are coming up and our timeline of getting recommendations to the changes in the waiver, and we're going to work hard as we meet together. So thank you all for making time to participate in the meeting. I'd like to suggest that for those of you who are members of the work group, that you do everything you can, and I know it's not always possible, to come to the meetings in person, because the meetings will be very interactive, and we can have more interaction with you, and you can have more interaction with each other if you're here in person. We'll make it possible for those on the phone to interact, but it's just easier if we can be here together. So please do that if you can. Before we do introductions, I just wanted to, so let's see if I can make the technology work myself. Okay, people. Okay, let's see. Okay, here we go. I just learned this new technology today. Can everybody hear me? I just want to review the agenda for today, and then we're going to have introductions of the work group members. So after we do introductions and find out who of the work group is on the phone and who's here in person, we're going to go over the purpose of the work group, the timeline, and what we have to get done before the end of this phase of work that we're in. Then we're going to start the conversation and talk about the current CBAS environment, what's working in managed care, what needs to be improved, and what are we looking for? What opportunities might be ahead in the future? So we're kind of dividing our conversations up between focusing on the waiver changes and some discussion about the future beyond. And at our last meeting, at our 3rd meeting, we'll also talk more about the future. So we want to really focus on the immediate, but we also don't want to limit ourselves just to the immediate work in front of us for the next 2 months. Then we're going to look at the special terms and conditions that govern the CBAS component of the waiver and the standards of participation. And we're going to talk about some work that we're going to ask you to do between this meeting and our next meeting as we get prepared to look over the terms and conditions
and identify which aspects of the terms and conditions should move forward into the new waiver and which ones are not necessary any longer. We will have an opportunity at each meeting to review input that we've gotten from the public, from any stakeholders, and we'll give you feedback on their comments. What issues are important to the people who are not official members of the work group but are important stakeholders in this process? And at each meeting we'll give you an update, and we already have some comments from them, so we want to give you their feedback. Then at each meeting we'll have public comment. That'll be a time for people who are here in the audience to take a minute, and if they have something that they'd like to share with the work group, to comment, and also for people on the phone, if there's something they'd like to share with the work group, we'll open up the phones. We won't open up the phones, excuse me. We'll have you type in your comments, and we'll read your comments. So people that are here in public will be able to speak, and people who are in the public on the phone will be able to type in their comments on the webinar computer. And then right before we end the meeting, we'll talk about the next steps, and we'll have you out of here on time at 5 o'clock. So many meetings like this are all day long. We arrange these meetings starting at 2 o'clock so that we can have many providers listening in and also participating in the meeting. And we have a lot to do in a short period of time. So thank you again for being here. So now we are going to go around the room. Let's see. Okay. And we're going to start with the people in the room who are members of the work group. We'll start with Ruth, and if you could introduce yourself, the organization that you're part of, and how long you've been connected to the Adult Day Health Center CBAS world. I think that'll give everybody just a chance to get to know you very briefly. Let's see. We're going to try this without the mic so that the people on the phone can hear. And Bill Henning, since you're my guinea pig today, Fred, let us know if you can't hear us.
Will do.
Thanks, Bill. Ruth, go ahead.
All right, I'm Ruth Gay. I'm the Director of Policy and Advocacy for the Alzheimer's Association of Northern California and Northern Nevada. And, well, I mean, I've been working with people with dementia in adult daycare for probably about 16 years in my role at the association, but certainly not a direct service provider.
Great. Thanks, Ruth, for being here. Diane?
I'm Diane Cooper-Puckett, and I'm the Executive Director of Innovative Healthcare Services. We operate the Peg Taylor Center for Adult Day Healthcare, which is the only adult day healthcare center serving Butte, Glen, and Sonoma counties north of here, which is a mostly rural area. And I'm the founding Executive Director, and I've been there since 1986 when we first opened the program for the community. Our center was also previously, when we had the Alzheimer's Daycare Resource Center designation with NCRC, and I had the privilege of working with Ruth way back when on the Alzheimer's Public Policy Council at that time. And I'm also a board member of the Alliance for Leadership in Education.
I'm Tammy Moore, and I'm from Santa Clara Family Health Plan. I became involved with CBAS as it was transitioning into the MCO. So, a year and a half.
Great. So, Tammy, we're going to try to catch each other on all of the abbreviations that we use. So tell everybody what MCO means.
Managed Care Organization.
Okay, Managed Care Organization. And Tammy is going to project so everyone can hear her. Great. Thanks, Tammy, for being here. Next time. Hey, James.
Yes, my name is James Kawakami. I'm with LA Care. My second day with LA Care, so I'll see that managed care environment I may not be able to provide much input on. My previous experience with CBAS was I worked for Department of Healthcare Services Long-Term Care Division within Home Operations Branch.
Lots of experience there. Thanks, James, for being here. Shirley, would you like to introduce yourself?
Let me see.
You don't have to get up. Just
I'm Shirley Parker, and I go to Escatón Adult Daycare Center in Carmichael.
great. Thank you so much for being here, Shirley. Presley?
And I'm Rosalie Marchand, Shirley's sister. We are evacuated here from Katrina. Oh, wow.
And had it not been for Escatron and you people here, we don't know what we would have done. My sister, as you can see, she doesn't see, and it has been a tremendous benefit for us because we're the only two here. We have no family, so now you are our family. And thank you so much.
And thank you both for being here. I told Shirley and Rosalie that we're counting on them to speak up, and I would call on them when we need to hear from them if we haven't heard from them. So there are self-appointed or group-appointed rabble-rousers, and I know they're going to do a great job of that. So thank you both, and what a story you have for all of us to learn more about. Thank you for sharing that. Mark.
I am Mark Kovalik. I'm administrator of Among Friends Adult Day Healthcare Center in Oxnard, and been doing it for past 13 years. And I'm also a member of CADS, and I'm on the board of directors of CADS and Alliance for Leadership in Education.
Great. Thank you for being here, Mark.
Hi, I'm Celine Regalia. I'm the program director of the Adult Day Services program at Napa Valley Hospital for Adult Day Services, and we're the only adult day healthcare in Napa County, and we started our program in 1998, and we're also an Alzheimer's Daycare Resource Center, and I'm also on the board of directors for CAD.
Thanks, Celine.
I'm Jeannie Smalley with Women's Healthcare Services. I work with long-term care division, and I work specifically with CBAS. So that's my main concern is getting the waiver renewed in the next few months. I'm Denise Peach, and I'm with the CBAS branch of the California Department of Aging. And I've been with the Department of Aging for the last 20-plus years, and have a lot of all that experience actually with adult day healthcare and CBAS. And like Jeannie, we're going to be integral to getting this waiver renewed, and we're very much now looking forward to getting all the feedback and moving this thing forward and into the next era.
So just so all of you know, if you have any questions, issues, problems, good news, Jeannie and Denise are in charge of this effort. So just go to them. They're great. Lydia?
Lydia Missalides, and I'm the Executive Director for the California Association for Adult Day Services. I've been doing that a little longer than Denise. We've aged in place together about 27 years now. I was supposed to be there 5 years, and here I am. And prior to my work with these wonderful centers and the state, I was 5 years with the Regional Center Association, so I have some experience with the developmental disabilities area, and spent 5 years working in community mental health with people who had been discharged from DeWitt Hospital directly into the community. That was the birth of my passion for home and community-based care.
Alcox, Graceful Senescence Adult Day Healthcare Administrator, Public Health Nurse, and passionate about the CBAS program. I'm also the CADS President. And having worked in multiple models of care, including acute care, home health, skilled nursing facility, I'm extremely passionate about keeping people in the community.
Great. Great to have you, Michelle. Thank you. Michelle Box with the Senate Budget Committee, and I've been covering Medi-Cal for about 2 years now. All right. We need you.
I'm John Chen from Department of Healthcare Services. I'm Chief of the Long-Term Care Divisions. I know about adult day health since 1979, and we have most of my career experience is building a managed care system surrounding adult day health, which is now called PACE. So definitely know the potential of adult day health center and now for CBAS centers, the ability of maintaining disabled and frail seniors in the community setting and working in a managed care setting. So definitely looking forward to continue to work with you, and I think we have very strong partnership with CDA to move this the adult day health and CBAS into a managed care environment and continue to be very productive in a managed care environment.
I'm Pam Lofer. I'm a gerontologist and Vice President of Long-Term Services for Care for Health Plan. And first became involved, I think, with adult daycare where I ran the area. So
70s working across upstate New York. So I've worked with managed health plans for over 10 years and 14 months in my current position of caregiver.
Hello, I'm Beverly Gibbs. I'm a registered nurse, public health nurse, and I'm the AVP of Medical Services for Care First Health Plan. I initially got involved with the CBAS program during the transitional period. I've been a nurse for over 25 years, and I've worked in the community of the underserved, primarily mental health, home health, long-term care, and acute care. So I have a wealth of experience working with different diverse populations.
I'm Ed Long. I'm Deputy Director for the Long-Term Care and Aging Services Division here at the Department of Aging, where I have the pleasure of working with Denise Peach, the Adult Day Health Care Branch, the pleasure of working with the provider community and policy. I'm a gerontologist, and I think my first experience with Adult Day Health Care was in the late 1980s, where I worked with Jill Youngling to develop a program for senior companions to work in adult day health care centers to assist with traumatic brain injury, and also when I worked in the community to make referrals to adult day health care centers for people living in affordable housing. So glad to be here.
Thanks, Ed. So now we'll go to the people from the work group who are on the telephone. Bill, why don't we start with you?
Okay, thanks, Bill Henning. And many, about half the room is pretty clear. Bobby, you're pretty clear. People who don't project quite as well, it's a little difficult to hear. So just a reminder to kind of speak up. I'm the Chief Medical Officer at Inland Empire Health Plan. We're the local initiative health plan for Riverside and San Bernardino counties. I've been with the health plan about 9.5 years now. Prior to that, family practice doctor down in the San Diego area, and it's probably many of us as health plans in this marketplace were the recent arrivals to the table for CBAS and Adult Day Health Care.
Thanks, Bill, for joining us. Who else is on the telephone from the work group? Please introduce yourself.
Pierre Chikarpetian from Southern California from the Adult Day Healthcare Association.
Thank you. We heard your flight was canceled. Thanks for trying.
No, the return flight was pushed back.
Well, you made the right decision to stay home, and we hope you'll come in person next time, first.
Yes. Thank you.
And we'll try to speak as loudly as possible so that you can hear us. We do have a few mics around the room, but everyone will project as well as they can.
We appreciate it.
Group on the phone.
Mallory Vega with Acacia Adult Day Services, also representing Orange County Adult Day Services Coalition. Our center started as an adult daycare program in 1979, became an adult day health care program in 1993.
Great, Mallory. Thanks for being here. Any other members of the work group on the phone?
My name is Robert McLaughlin. I'm the consultant with the Assembly Committee on Aging and Long-Term Care. And I've been involved with adult day health care since the late 80s. I believe my grandmother was a participant and a volunteer at Eschaton in Woodland, and have worked with the Senate Subcommittee on Aging and the Department of Aging at one point or another, as well as the Commission on Aging throughout the years.
Great. Thanks for joining us, Robert.
My pleasure.
Anyone else on the phone from the work group?
Yeah, this is Dr. Wendy Tong. I'm with Anthem Blue Cross. I'm the medical director for Northern California. I also lead a work group within Anthem where we're looking at promoting quality of care with our CBAS partners, standardizing some of the processes, and also doing some advocacy work because we do see the value of CBAS, especially for our SPD seniors and people with disability population. Thank you for having me on this group.
Thank you, Wendy, for making time in your schedule to join us. Anyone else on the work group who would like to introduce themselves?
This is Viviana Criado. I'm with the California Elder Mental Health and Aging Coalition. I'm here representing older adults and family caregivers. are suffering or living with mental health issues. I'm familiar with adult health services since the early 2000s. Most recently, about a year ago, as the programs were transitioning into CBAS, I had the opportunity to provide basic mental health training in Alameda County to a network of adult day health centers. I'm familiar with some of the predicaments that they have as they relate to mental health needs of that community, and I'm honored to be asked to be part of this group, and hope through my advocacy efforts to be able to improve the quality of life and mental health for older adults and the service providers.
Great, Viviana. Thank you so much for being with us. Anyone else from the work group on the telephone? Okay, well, we will check in to see if anyone else has joined. I want to make a special introduction to someone who many of you know, Dr. Lisa Sugarman from the SCAN Foundation. The SCAN Foundation is supporting this effort, and we really couldn't go forward without their help in a whole variety of areas related to long-term services and support. So Lisa, thank you for being here, and thanks to your organization for all your support. So we're going to move on now. In your packet of materials that you received in advance is a list of the work group members. We will update this with any changes and get this out to you after. And this will also be posted on the website so that all of the stakeholders knew who the members of the work group are. Let's now just stop for a minute and review our purpose and what we're all about here, what our work is. And I'm going to go through this rather quickly because you've all seen the materials in advance. But as Laura said when she introduced herself a little while ago, our focus is twofold. First, we need to make recommendations for amending the CBAS Special Terms and Conditions, otherwise known as the STC. So we're not talking about motor oil. We're talking about the Special Terms and Conditions. It's a federal term that lays out the ways that the 1115 waiver will affect the CBAS program and the standards of participation, or the SOPs. And you've all seen those, and we're going to be working with both the Special Terms and Conditions and the standards of participation at every one of our meetings. So you'll have to memorize before we're done. And then we're also going to focus on what are some important recommendations for the future of the CBAS program beyond the 1115 waiver. But our immediate focus is on recommendations related to amending the 1115 waiver. As was already mentioned, we have a very tight timeline. In February, the Department of Healthcare Services will begin or continue their conversations with CMS, the federal government, to amend the 1115 waiver to include our suggestions and recommendations. So we have a meeting, our meetings coming up will all be building to these conversations that DHCS, the Department of Healthcare Services, will be having with the federal government. In May, the waiver amendment must be submitted. In August, the current CBAS waiver components, the waiver has many different components. In August, the CBAS waiver expires. So we have to get our recommendations and the state's recommendations into the federal government with enough time for the approval process to happen before the end of August. The new waiver, including all of your thoughts, will go into effect on September 1st, 2014. So we've got a very tight timeline for the work that we're undertaking, which is why we've structured the work in the way we have. I think everyone has our meeting schedules. We'll be meeting each month, one time, in December, January, February, and March. We have 4 in-person meetings from 2 to 5. They'll be held here. And then in April, we'll have a wrap-up webinar that will summarize the work that this group has done and also update everyone on the conversations that DHCS is having with the federal government related to the changes in the waiver. So let me just go back and make sure that everybody marks their calendars with these dates. And again, just to encourage the work group members as much as possible to be able to come in person when possible to the meeting. Okay,
so this is Sonia Bjork at Partnership Health Plan in California.
Hi, Sonia.
Hi, I'm on the work group too. I just wanted to let you know I was here. And I wanted to confirm the upcoming meetings, are they all in the same location?
Yes, they're all here at the California Department of Aging in Sacramento, 1300 National.
Thank you.
Great, I hope you can come in person next time.
Yep, I will.
Good. Thank you for letting us know that you were on the phone, Sonia. Okay, we've already talked about meeting one. I just wanted to give you an overview of the upcoming meetings. The January and February meetings, we are going to basically dig in to the special terms and conditions and the standards of participation. We are going to work in small groups on groups of the STCs and standards of participation. We're going to bring back recommendations for full discussion with the group about which items should be kept and which items should be modified and which items can be deleted in the new waiver. So our work is really going to be heavily focused on those two documents, which we're going to review later in the meeting. I believe all of you have them already, and we're going to send out a homework assignment to members of the work group after the meeting for which areas we'd like you to study in advance of the next meeting. So we're going to have a robust discussion at meetings number 2 and 3, and we have a grid that we want you to use, and we're going to really work through each one of the STCs and the SOPs to get your input on how we should move forward. Meeting number 4, we will review your recommendations, so we'll work on them at meeting number 2 and 3. At meeting number 4, we'll summarize and make sure that we have agreement, and where we don't have agreement, we can identify areas of disagreement. And then we'll continue talking about the medium and long-term opportunities for CBAS and the next steps. And then when we have our final our final webinar meeting in April, we'll review the progress discussing these issues with the federal government. So as I mentioned earlier, each meeting will include action items that were discussed at the previous meeting. Each meeting will review the stakeholder input that we've gotten in between the meetings, and each meeting will have public comment. So there'll always be an opportunity for stakeholders who are either attending the meeting in person or on the telephone to provide comment. Okay, first of all, does anyone have any questions about what our job is? Because the most important thing is that we're clear about what our assignment is. So let's just stop for a minute and see if any members of the work group, either on the telephone or here in the room, have any questions about what our assignment is. Yes, Lydia.
Are there any boundaries or parameters for our discussion? Are we focusing strictly on the SPCs and SOPs, or is part of what you were saying about medium and long-term future opportunities sort of a catch-all for ideas that might emerge?
That's a great question. So I think here's our thinking, and see if this makes sense to everybody on the work group. Our thinking is that we're going to focus very specifically on the STCs and SOPs in terms of which ones should continue, which ones should be modified, and how. What's missing that you might want to add to the STCs and the SOPs? And we're going to also, we're going to try to segregate the two conversations. Sometimes it'll be hard. We're also going to talk, and we're going to start that in just a few minutes. What does the future look like? What are some opportunities long-term for the expansion of the CBAS program? What are new ways that the managed care programs and the managed care plans can use CBAS in ways they've never thought of? What does the future hold? So we're going to try to keep them separate, but they do kind of overlap, and we'll keep really good notes so we can keep going back to the future issues. Does that make sense to everybody? Lydia, does that help?
Yes, that helps.
Okay, good. Thank you for clarifying that. Denise, please.
Yeah, I'm looking at a lot of the feedback here, and we know we're having some issues with our sound, and we do our best to avoid it. And usually says that we're gonna have to break at some point. We'll come in and try to fix some of the mics here. But if we can just ask everybody to project this, and then maybe Bobby, you can repeat some of the questions and make sure that we get it clear for the people in the audience. Yeah. And then just one more thing that we wanted to emphasize, a lot of people are typing in and saying how can they make their voices heard, and they can make their voices heard through, if they're not actually a work group participant, a member here today, they can email us. There's information for contacting the department and getting feedback in this process is all at the end of the slides here, and they're on the CBA website. So I just want to emphasize that now in case anybody else is having anxiety, that they are going to be able to send us emails, send us written feedback, and all that comment information is in the back of the slide.
Great.
Can you just repeat that for people that might not have heard it?
Yes, thank you. No, that's great, Jeannie. So a couple of things. We've gotten some feedback, just to repeat what we just heard, we've gotten some feedback via the webinar that if people are having a hard time hearing some of the comments, and we're all going to talk as loudly as possible. For those of you that are not here visually, we're sitting in a fairly small square, or rectangle, I guess, and we have a few mics around the room, but obviously it's not enough to hear well on the telephone, and we apologize for that. We will all do our best to speak as loudly as possible, and I will repeat as much as I can so that you don't miss too much. And by the next meeting, that will be significantly improved, I guarantee it. Secondly, if you have comments throughout the meeting, after the meeting, or ideas that you want to provide directly to the work group, you can send them in. There is a slide at the end of the meeting that you'll see, and it's posted on the CBA website, where you can send comments in. And at each meeting, we'll summarize, and we'll do that today a little bit later in the meeting, the comments that we've received so that the work group members get a sense of what the comments are. The staff are keeping a log. They'll be responding to comments and questions as they come in. So we'll integrate comments from the public throughout our discussion. And again, I apologize if the sound quality is poor today. We will definitely do our best to work on that between the meetings. Okay, all right. So we're going to get started now with our discussion and hear from you all. Let's see if I can make this work. Here we go. So we're going to start by having a large group discussion. We want to hear from everybody about these three questions that I hope all the people on the phone can see, and I know all the people, most of the people here in the room. I'm going to read the question, and then we're going to talk about them one by one. So the first thing we want to talk about, really think of this as the beginning of a planning exercise. We've had the transition of CBAS into managed care. What's working well? Where have you seen some real improvements and gains for the program? And we know that everything's not rosy, so we don't want to end the conversation there. But we do want to hear what have been the assets of being affiliated with managed care. Secondly, we want to talk about what needs improving within the managed care system and within relations with the state of California. So what needs improving? And then we want to stop and think into the future. What are some opportunities going forward? So this is a chance for everybody on the work group to kind of start talking to each other about what the key issues are uppermost in your mind. And I'm going to stop for 1 minute and ask Pollyanna here for some technical help, because I'm going to actually record the conversation on this whiteboard so that the people on the telephone can see it. So what do we do? How do I do that? Oh, take a pen. All right. So I don't have to get this white sheet. Unless you want to. Yeah, I want the white sheet. Put the pen down. All right. Awesome. Okay. I want to hear from the people on the phone. How about this? Okay, what's working in managed care? So I'm hoping that no one will judge me by my handwriting, and that people on the phone can see the list, and also most of the people here in the room can also. So what's working well? Lydia, start us. Me? Yeah, you.
Provider.
It's okay. We'll hear from everybody.
What's working well?
And speak up.
Okay, let me think about that. I think what has worked well from where I sit, and I'm not a provider, so I don't work directly with participants, on the ground, but the feedback that I'm getting, I think what's working well is there has been a very can-do, positive relationship and spirit and attitude. We kind of joke about this shotgun marriage between the plans and the centers with the participants and families, and I've been very impressed with how everyone has really worked together to problem solve. There were a lot of bumps, as you said, especially with the early months of the transition, but I think on all sides, the participants and families were as patient as they could be. The providers were really good about bringing issues to us, you guys, and the plans for the most part were responsive and tried to solve problems as quickly as possible. So I think that attitude going forward will serve us well with the next set of changes that are coming. Right. And I think that has been reflected in people really wanting to do right by the beneficiaries in this whole process and keep the changes as sort of far away as possible as humanly possible with so much complexity.
Right. So Lydia commented on the can-do, positive spirit, this relationship that's now developed, a new relationship between centers and the health plans. But the plans are focused on solving problems as fast as possible, and that there's been a real focus on the client or the beneficiary. Other thoughts, and you don't have to agree with all of this, so we'll get a chance to talk about what's not working as well. Rosalie.
I'm very happy when they send all of these changes that we didn't know anything about. Medi-Cal, Anthem, Blue Cross. There were certain things that we could not handle, and I take my sister to the doctor. They didn't want to take care of us. But managed care at Escatron took care of that. They sent a letter out, and that enabled us to bring this to the doctors to make them understand and stayed on them so they would treat us well.
Right. So you got communication both from the state, your health plan, Anthem Blue Cross, and your CBAS center that you were able to use to talk to your doctor
about resolve that issue. Yeah.
Right. That's great. Thank you, Rosalie. Shirley, anything you want to add there? No. Okay, good. Ruth.
I think, again, in all the shuffle of the changes, it was challenging. I think what one of the results has been is that the programs have actually become models of education and support for the plans who were somewhat underinformed, perhaps, of the clientele, the degree of impairment, and especially when you roll dementia into any of that. And I think the plan's background, if you will, as educators and trainers and models for families carried over well and has continued to do so for the plan.
Great, great. So just to repeat, for those of you on the phone that might not have heard, the CBAS programs have become models for the health plan. They've educated the plans on the client's needs. This is an area that the health plans have not worked in before, and also have helped the plans understand the role of the family in supporting. Thanks, Ruth. And I don't want to underestimate what Ruth said, that the transition was not easy. We don't want to sugarcoat that in any way. Point. And then we'll go to Nina.
The biggest thing has been just the aspect at the local level of being able to communicate and expedite things with the plan. So if there's a participant who has changing needs, the plan knows them because they've known them in the center, and we can communicate more and activate things much quicker than we could in the past under managed care.
In the got a local health plan with offices close by, and there's easy communication. They know their health plan. The health plan knows them. They're getting to know the client. It's not like dealing with the behemoth state of California. It's a very close relationship. That may not be the same in every community. Okay. So, Nina, let's go to you, and then we'll go to Mark.
I was going to kind of build on what Ruth talked about. First of all, the plans know us. They didn't know who we were or what we did. So I think that that's a really big positive. And I think that the fact that we were the predecessors for the transition, I think that we really have great insight for thinking about the CBI because we knew some of the challenges that accompanied this transition. So we really can be of great help there too.
That the lessons learned from this transition will lay the groundwork for CBI transition. Really good point. Thank you, Nina. Mark.
We experience very fast accommodation for face-to-face assessment.
People on the phone. Okay. What shall I tell the people on the phone? What should they do? Okay. For those of you that are on the telephone, if you could use your cell phones or other phones far away from your computer because it's interfering with the sound here for all of us. Thanks, Bobby. Please. We've got a second mic, and if we could take just a couple minutes, we can add that mic in. Okay. Yeah, can you just, let's just finish hearing from Mark, and then we'll just take a 2-minute break and see if we can get better sound. Go ahead, Mark.
The comment I wanted to make is that we experience very timely face-to-face assessments with the plan. And that kind of expedites the admission process. Yes.
I'm sorry, Mark, you're saying that it is timely, the face-to-face process?
Yes, what Mark said, is that you, Bill?
This is Berge.
Oh, Berge. So what Mark's saying, and see if I've got you right, is that in the counties where he's working, they have a timely face-to-face assessment, which accelerates the admissions process into the CBAS program. Okay.
Bobby, this is Sonia at Partnership. I had 2 things to add.
Okay, and we're going to, Sonia, we're going to take your 2 things, and then we're going to take I hope a 2-minute, we're going to stop for 2 minutes and see if we can add some more microphones. We're not quite sure if it'll work.
Oh, okay, great.
Go ahead, Sonia.
The first is that the CBAS leaders at the different programs in our service area are active participants in our health plan now, meaning that they participate in our provider advisory group meetings that we have quarterly. And they've also come to different case management programs and things that we offer here at Partnership or that are occurring, with other providers. The second thing is it's gotten us more involved in community events related to CBAS beneficiaries. Like now we're more active in the YOLO Healthy Aging Alliance and things like that because of our relationship with our CBAS providers. So it's been very helpful, and it's caused a change here that's for the better.
That's great, Sonia. Thanks for those 2 items. We can hear you better than we can hear each other, so maybe we'll all get on the phone. Thanks for those 2.
Yeah, there is one that I don't see in what has been mentioned. This is Berge. I would add the timeliness of the approval of TARS.
This is Wendy Tong. I just wanted to say our nurses at Anthem have developed a really good relationship with the staff at the CBAS facilities, and I think a lot of it stems from the requirement for face-to-faces, and it really helps in also seeing the facilities, understanding their services, and being able to, share that with the rest of the team is sometimes they also discuss our complex patients with case management within Anthem.
Thank you both for adding both of those two things. Yes, Ruth, we'll just keep going. Yeah, go ahead. So, no, not quite yet.
Okay.
So, and I'm speaking now, I'm not a provider, so I may be corrected on this, I'll say. I think during the transition, which was very difficult for many of the providers, and not everybody made it, right? There's a lot of different fallout in terms of the programs. But I think the programs that are continuing to move forward now are more sophisticated. They're more coordinated. They're more capable at dealing with the regulatory end. And I think that was something that was very hard to have happen. But the ones who are doing it now have expanded and are doing more things than they've done ever before, either. So perhaps that transition enhanced the programmatic breadth of what's offered and how it's offered and the quality of it. Interesting. But let's just hear from people how they feel about what Ruth just said in terms of that post-transition, the centers are stronger, they're more sophisticated, more skilled, they're expanding. Is that the experience of others, Diane?
Well, it's not uniquely our experience. I think we've been very involved from the beginning, and as a center that has worked through a lot of transitions in our state over the years and really worked towards quality. I'm not specifically relating to that comment for us. We also have not yet experienced managed care. So
just starting in the rural.
Yeah, it hasn't reached our county at all for us yet. So it'll be implemented in the future. So, I'm sure in terms of working with managed care, that'll be a change for us in the future to that county.
Others want to comment on Ruth's comment? Any thoughts, Lydia?
Well, what came to my, I have a loud voice. What came to my mind when Ruth said that is I've kind of joked over the last year with our providers that they went from a single payer system to the American healthcare system. And I think that they have, to your comment, Ruth, I think that they really have risen to the occasion. We have been, as a system, a EHC system, really living in the long-term care world and not in traditional healthcare, let alone managed care. So to both experience the transition with all of the work they have to do with participants and families, understand the different plans, how they did business, the billing, all those complexities at the same time, I think is a testament to the flexibility and the willingness of the centers to adapt. And I think likewise, the centers have changed the ecosystem, if you will, of the managed care environment as they have moved into that world in the last 18 months or so. And I think that will continue to evolve.
Good point. Okay, we're going to stop everyone for 2 minutes. This will be a great time. You have to go to the bathroom, but don't go too long. And we're going to see if we can add some sound. So those people on the phone, just hang tight. Don't hang up. I'm going to put you on mute just so you won't hear the noise in the room, but we will be right back. If it's more than 2 minutes, I'll come back and tell you. So just hold on, everyone.
I was thinking it also showed that care plan with strong advocates the centers are for their participants. Mm-hmm.
Plans are present at this.
Well, in terms of the work groups, there are in terms of this work group, there's Inland Empire, LA Care, Anthem Blue Cross,
partnership, health plan, and care first. But they
or different height. This is sharp. It covers 180 degrees.
What's the best place to stay?
So this is the new mic. So capturing sound a lot better.
Oh, okay, great.
This is just hair replacement, but
Okay.
it covers like this, so you want to stand.
Okay, what if I stand back here?
Because I'm going to try to ride. Okay, yeah, I'll try to stay close. That's fine. No, I want them.
providers.
Family providers.
And friends, but don't they help? You know, I feel like if they really are going to continue to
Oh, yeah.
So, is that any better, Bill?
I'm unmuting all the.
Someone has their computer microphone on instead of. Okay, we'll try that again. Let's see. Sonia, can you hear me?
Yes, I can hear you just fine.
Oh, good. And Bill, can you hear me?
I hear you well.
Oh, good. Mallory?
I can hear you.
Awesome. Okay, let's see if this works. Thank you, CBA staff. We're going to keep our fingers crossed that this is better for everyone on the phone. I guarantee you that at our next meeting it will be different. So I apologize again. And if I trip and you hear a big thud on the floor, it's because there's wires now all over and I could easily fall over. We got comments that it's much better sound. Much better sound. Awesome. Okay, thank you. Okay. So while we had our break, did anyone on the work group, on the telephone or here in the room, think of any other assets to working with managed care plans? What's working that we haven't mentioned yet?
This is Mallory. Two things that came up here. One, that both the CBAS providers and the managed care providers are finding that they're both strong advocates for the members.
Awesome. That's great.
And also that the managed care plans are finding that CBAS is a new tool to add to their belt of services that helps them better manage their members.
Good. So that's great, and I want to see if the plans agree with what Mallory just said about a new tool for the plans to use to support their members. What do you think, Tammy?
That's definitely true. A lot of our new referrals come from case management, hospital discharge, so it's been a wonderful gain for us.
Great. How about you, Pam and Beverly? Would you agree with what Mallory said?
Absolutely agree. I would agree with what Nina has said, that it's great that we've started this process of working together with the aging network, and it's definitely lessons learned with the CCI coming down the pipeline.
I agree. From a case management perspective, it's a wonderful resource for families as well as for the members. And I want to say our experience in managed care with the centers is I feel that we're procedurally congruent with them now over the past 14 months. And with that being said, it opens the door to us to have a more meaningful data exchange in terms of the treatment modalities and the medical information that would support us to better manage the patients at the health plan level. So it's been a great way to start. And I will say procedurally we're there. And now how we can more meaningfully exchange quality data is the next challenge.
Right. Good point. So let's start there with, that's a great way to start the improvements, and that is exchanging quality data. So we're going to move now into talking about what area, sorry, go ahead, Ruth. Well, just a broader expansion on that. Again, speaking as an outsider, I'm not a provider. I think one of the things that is and maybe I'm moving into the wrong area, maybe it's like an opportunity, but one of the things we always dreamed of in the work that I do is if you could get physician groups to make direct referrals for families to adult daycare, to care management, to whatever service is appropriate, and that was like the dream that we could never get. And now what this has done is put us in a position where there is an automatic linkage. Now I realize we've got a ways to go and maybe that's more of an opportunity, but the idea that the managed care plan and the physician plan has that at their fingertips as a tool right now to send people to was something that we never had before and is now sort of a new opportunity. Like I said, I'm not saying it's working perfectly like that now, but I do think that could be on the horizon.
Good. So I think this is, we'll capture our opportunities list and we'll come back to this in just a few minutes. So what else needs improving? So Beverly started that with the exchange of quality data between the plans, the physicians, and the centers who see the clients on a regular basis
needs to be more robust. So, like, what else?
Along the lines of
The
data.
biggest issue for us is still it takes a long time. Once a referral happens, even though the face-to-face is timely, it still takes to get the history and physical and all those things for a family who's in crisis. It still takes them sometimes 30 to 40 days to get into the program when they have an immediate need. And with that, also being able to respond to the other end of that when somebody is coming out of the hospital and needs to be immediately admitted into the CBAS center or coming out of the skilled nursing facility, to be able to respond more quickly. Our process is still really cumbersome.
That's a concern of us too, the expedited referral process, and what do you do in the interim while you're getting all that paperwork, and that's something that we could look forward to for our future improvements. So the transition of people into the program is often taking longer than you'd like. Both the health plans, from the health plan's view and from the center's view, and probably from the clients as well. Okay, I think somebody on the phone wanted to say something a minute ago. I couldn't recognize.
This is Wendy, sorry. I see a lot of fragmentation in data. When I actually visited Molly Steiner at Mission Creek, sometimes they don't know, if a patient's been hospitalized, which actually the managed care plan, would have maybe some of that data. So again, sharing that data, and also, from our point, we may not even know, why a person, who's approved for 5 days a week is, only just being able to make it for 3. If there's any other, are they being hospitalized? Are they going to SNF? Are they having, so because typically these complex patients are just getting their care and their caregiving services in so many places, that really causes a lot of the fragmentation in the data, and it affects the transitions in care. And of course, this is a problem that's vaster than just CBAS, but it's definitely a problem.
Right. Was that Wendy? Yeah. Wendy.
Yeah.
Okay. Thanks, Wendy. I just wanted to make sure. Thank you for that comment.
Bobby, this is Bill. Can I make a comment?
Please.
So what started me thinking when we were talking about some centers being stronger, it's also true that we have at least one center that's on the verge of closing. And when we try to drill into the problem, the decreased enrollment problem, the best we could figure out was that it was decreased enrollment because of the mandatory managed Medi-Cal requirement for the people who were enrolled in CBAS now. And so they were sort of coincident in that, to be in a CBAS, you had to be in managed Medi-Cal at the same time they were being given us as risk. And what happened was that a lot of the clients in the CBAS centers tend to be centered in a few attending physicians. And so the medical director at the center may have half of the patients in a CBAS center, and if that physician happened to be a foe of managed Medi-Cal, he was telling his patients to disenroll from IEHP and go back to fee-for-service, and as soon as they did that, they lost their ability to go to a CBAS center. And so the opportunity or the improvement that's needed is probably some outreach into some of those physicians and into the physician community, encouraging them to encourage their CBAS members to stay in managed Medi-Cal, encourage more people to get into managed Medi-Cal so they can access the benefit.
That's a really good point, Bill, and I think something we saw in the SPD transition and we know is coming with the CCI is the role of the physicians, their attitudes, and it's hard to educate those physicians about what might work differently. Nina.
So to kind of further build on that and what Ruth you have on in the parking lot, the managed care administrative levels know who we are. But you start going through the layers, and the ones that we interact with sometimes don't.
Meaning the staff, meaning?
Yeah, let's say that the calling staff. So we could call in, and it's gotten better. But it needs to be throughout the organization. It seems to be not consistent throughout the organization. So we can call in possibly to the managed care, and still, if we're calling with a challenge, they may not who is CBAS? Oh, you're assigned to an IPA. And so we're still having some of those types of challenges where there's some confusion. The other thing I want to mention is the lack of incentive, kind of going back to the point of the MD referral. As we continue to be with long-term support services heading into Medi-Cal managed care, there's still potentially the disconnect unless they become part of the Cal MediConnect Duals project. There's still the potential for that disconnect. We are experiencing that right now. And an example of that would be a beneficiary who has Kaiser but has LA Care for their Medi-Cal managed care. And so still the right hand doesn't necessarily see what the left is doing. And the disconnect that goes along with that with regards to talking about the fragmentation. And the last thing I want to mention is I am confident that we are not being utilized to our best capacity. We're talking about a program that is really intimately involved in these people's lives. We have a lot more information than the plans do frequently. And a best example I could say is maybe an example of the health risk assessment, which could be performed over the phone with the plan. Well, we see these people, and there's nothing like a senior telling you, "Oh yeah, I can do that," or "I've got that," or "That's fine," versus actually laying eyes on the individual, which is something that we do. So we're just not being utilized to our best capacity.
So I'm going to put that on this opportunities list because that's one of the issues to think about is how can the role expand? Beverly. On that note, the CBAS centers are in an opportune position as well with the mental health component.
Absolutely.
That's been a very fragmented system. And a lot of times we're not even aware until we get a member of the CBAS program that they actually are under behavioral health management, and if they're on any of the antipsychotics, and anything to that effect, we have no knowledge until they get in the program. So it's really a holistic center in terms of that.
We are the best kept secret.
Right. Well, let's get that up.
This is Paige. I've got one area that needs improvement.
Yes, Barrett, go ahead.
The transition, the care coordination or the possible loss of care when a participant transitions from one facility to another or from one plan to another. Certain plans now require face-to-face to be done again when a patient changes plans but still stays within the same facility, and when a patient stays in the same plan but changes facilities.
Yeah, very good point. Can you give an example of that so we're sure that, I'm sure lots of people have had this experience, but give an example that you've experienced directly.
Well, we've had a patient that was in HealthNet, and the doctor, primary care physician, has decided that her patients should be in Care First because she's now with Care First, even though Medi-Cal managed care should not make a difference to her. They're Medi-Medi patients. But she's had them enroll in Care First, and now Care First requires to come and do a face-to-face before we can continue providing care to that person.
Great. That's a great example. Thank you. Nina and then Ruth.
I have another more challenging example.
Yeah. The more specific, the better.
Yeah. So this is the participant who has a chronic illness that requires a medical intervention such as plasmapheresis about every 6 to 8 weeks. This was set up with the LA County hospital system. So he was going in every 6 to 8 weeks to maintain his health status, maintain him in the community, and he signed some papers changing his plan. And he didn't know, he didn't tell us. Someone approached him, a marketer. So when he gets to go get his treatment, they won't perform the treatment. And it took us probably about 30 to 45 days to get him transitioned. In that time, the very difficult thing, because it was a specialized treatment, he had been assigned to a physician because he signed over his Medicare and his Medi-Cal over to this plan. They assigned him to Orange County. Well, he lives in Los Angeles. He uses Access Paratransit, which will not take him to his treatment. And we can't get him there. And it was just a disaster. It took us quite a bit of time to get him disenrolled. So we have to have some things in place moving forward to deal with this specialized population and be able to troubleshoot. Because he had an advocate, and it still took us 45 days to get him transitioned. So can you imagine those that won't have that kind of support?
Great example. So this whole timely transition from one facility to another, from one health plan to another, has to be focused on. So that's something I think we have to think about as we're looking at the STCs and thinking forward. Bruce, you want to add something?
Yeah, so I think one of the things we've been concerned about is some of the assessment tools that the managed care plans use as they interview their folks may not have distinct questions around dementia, or they may not distinguish between dementia and mental illness. And these are folks that if you miss them in that or you get the wrong information, it has dire consequences for whether they get referred appropriately later. And they all seem to have their own differences, some more than others. But I think there also is sort of a lack of awareness, for perhaps, that even if you have the right questions, you know, Mrs. Jones, are you on any antipsychotic medications? Mrs. Jones, are you experiencing sun-counting behavior? Mrs. Jones, you know, those kinds of things are not going to get the answers that you want, even if the idea of that is correct.
Not at all, Bruce.
That's fine. So I just wanted, I don't know what the right answer is for that, but I think we need to look at how that initial impact of managed care to an individual is handled, and are they able to distinguish those?
Yeah, really a great example. It could apply to a number of different conditions.
That has been our experience. It's very generalized. A lot of times we'll see, you know, forgetfulness or anxiety or sleeplessness. And one of the things that internally, we do have a CBAS department, by the way, and you know it's very tight-knit. We have looked at ways to perform outreach with the primary care providers to get a confirmed diagnosis of Alzheimer's or dementia, so that they can appropriately be managed. And there are tools on the state website, Department of Health Services, for the assessment when the RN goes out to do the face-to-face. But it would be ideal if a physician would confirm that diagnosis.
So kind of to build on that, the health risk assessments, we're working on this statewide uniform assessment process. All these health risk assessments are different. And there's, you know, something that focuses to identify our population would be really helpful. But it's something that identifies what services might be appropriate if they did that kind of work.
I think a lot of that also is going to change once we're responsible for the MLTSS under the CCI, because then we're going to be looking at the whole person holistically. Right now, our experience has been medical only, and then we got added CBAS, which really now is more of a medical model than a social model. So it's still the medical focus. I think a lot of these other, like, you know, dementia and behavioral health and all these, and we'll be assessing for other LTSS needs as well. I think a lot of that will go away.
So that'll be one of our questions about the future is, will CCI be an opportunity to do even more for the blindness with these special needs? Other areas of improvement? Yes, Nina.
The actual assessment process. that currently, the things that we've set up are things that were set up as a direct result of the settlement. And so moving forward, I think that should be, we should look at that.
Okay. I'm going to put that in both places. Okay. We'll go back to these messy lists of mine. Good. Other areas of improvement. Those of you on the telephone from the work group, any other areas of improvement that you haven't heard mentioned yet?
This is Mallory. I would say also when, in terms of transitions, also when a participant comes to a point where they need to transition from the CBAS provider because it's now has gone beyond the ability for care, and how to create a transition process where the communication between the CBAS provider and the managed care provider connects and makes that an easy process, because that's probably the most difficult process.
And so when a client has to go to a more acute setting, working with the health plan around making that happen?
Yes.
Okay, good. Thank you, Mallory, for adding that. Nina, and then Lydia.
Data sharing, kind of going back to that, I know that the plans have a plan of care. I've never seen one. And, you know, I could really, I'm in a great, unique position to help them meet their goals, but I don't know what they are. So I heard someone talking about data sharing, that they do that. We should definitely have better lines of communication, as well as solid pathways of communication for the center to the plan, so that when we have a challenge, when we need to advocate, that we know where to go and we're not fumbling. Right now, there's a lot of fumbling. My social workers and nurses are reaching in multiple directions to try to troubleshoot.
Yeah. Two great points in terms of how can the CBAS staff be part of the care planning review, or part of, in CCI, the interdisciplinary care team, how can they be included in sharing of that information and offering feedback in terms of that? And then having clear paths of communication between you and who in the health plan should you go to for different issues. Great, thank you. I'm sorry, Lydia, and then Beverly. Sorry, Beverly. Go ahead.
I was going to make the same point as Nina, because as I've been meeting with the plans because of our special health home project, it has been interesting to find out that often someone who's very high on the radar screen of the center as high risk, very complex, has not made it on the radar screen of the planning. And I think it's because of that fragmentation still, that Medicare is responsible for the bulk of the health care, not the plan. These have a little sliver. So I hope one of the improvements as we move forward in August, hopefully there will be CCI, that we will have worked out some better communication channels, as Nina said, so that when a plan identifies a highly complex, high-risk person, that could be a referral, and vice versa when the center identifies those folks, it's in sync with what the plan is working on. So that whole system, I think, is a whole conversation in and of itself. And it would be nice to have a little, we can't be identical across the plans, but some commonalities. And that gets me to sort of core data elements that all the centers and the plans are interested in collecting. So an improvement would be identification of those important core common data elements, and then that leads to what Denise and I talked a lot about, which is, you know, at some point, I don't know when it is, we've got to take another look and run an individual plan of care. And my vision is that we turn it more into a clinical tool that makes sense for the center, the plans, and the patient, as opposed to what it is right now, which is what I call the Winchester mystery house of a care plan, where it's just been added onto over the years and really doesn't hang together very well anymore. So that would be one of my improvement goals, would be really taking a look at what's the purpose of the individual plan of care, it's fundamental, and then revising it to match all the other good things that come out of this process.
Great. Thanks, Lydia. That's pretty much where I was going. If you look at the program, there is a lot of eligibility criteria. But then what criteria
constitutes a modification to the care plan, an increase in days or a decrease in days. So it's really got to be criteria focused too, because also in the event, you know, that a center submits and they get denied because they don't appear to meet criteria, and it goes to a state-based hearing, that judge, what are they using for criteria? So we have a dearth of information when it comes to the criteria and having standardized criteria across the board.
Good. Okay, let's take one more round on improvements, and then we're going to spend about 15 minutes thinking about the future. So Diane and then Mark.
Well, this relates to what Liddy was just describing, but I wanted to kind of note it in a slightly different way, and that's that in terms of really being able to keep the people that CBAS is intended to serve in the community, the earlier that we can reach them relative to their need for ongoing care for their chronic health conditions, the better job we're going to be able to do it at preventing crises that might take them beyond the point of being able to be served by our programs. So, you know, the improvements and the opportunity of being able to use the data that we can develop to really look at people who are showing up with this need even before anybody has started to think about CBAS, and then see whether CBAS matches those needs, I think is really great, and something that would behoove a lot of time to look at how that can be done effectively. Because it's always been hard for families and individuals to find the services that they need when they need them.
Really good point. That's a really, really important point. So that's also part of our vision for the future, how to reach people sooner. Let's see, somebody else want to say something here in the room before we go back to the phone? Yes, Mark, sorry.
One more comment.
Right.
We were discussing the possibility to have like standardized assessment statewide. The reason why, because there are a variety of NCOs and everybody runs their own organizations, but you know, if we would have a chance to have standardized assessment tools, that might be an area to look into.
Yes. Good. Thank you. Okay, on the telephone. Any other improvements that you'd like to add to the list? Comments that you'd like to make?
Yeah, this is Wendy. I actually have a best practice to share. I actually started doing CBAS rounds with our statewide CBAS nurses who are at the front line, you know, doing IPCs and CDITs, and they would bring cases that they had, you know, they felt were more challenging than the usual routine, or if they had questions. We only started doing this about 3 weeks ago, and basically we discuss these patients. Sometimes it leads to me picking up the phone and talking with the CBAS medical director or the CBAS or the PCP, or coordinating care with our own Anthem behavioral health folks or social worker folks to augment what the CBAS staff are able to do. So those have been really helpful. I initially started doing them just to kind of learn, you know, about you know, CBAS clients, you know, what you know, just to get a feel for them. But they've been really educational, both for myself as well as my team, because our CBAS nurses oftentimes work in isolation, and then they get to share, you know, some of their experiences and their learnings with CBAS nurses, you know, throughout the state. So I really, I'll let you guys know about how those go later on. The other thing at Anthem that I'm working on is actually developing a CBAS tool to ascertain, you know, what's appropriate amount of days of service requested. So it's something that Lydia Mercedes has been helping me a little bit on. Once it's in a better format, we're trying to do some validity testing and some calibration of this tool. But once we have a better version of it, hopefully by the end of this month, I'm certainly you know, open to sharing it with this group and having other folks test it out in their managed care plans and see how they do.
Great, thank you. And keep us posted on how these two projects are going. We're going to hear more as we move through our process here. Anybody else have any areas of improvement?
This is Mallory. I would say, and this may have been brought up before, I can't remember what was all written on the other board, but however the plans are marketing the lines of service that they provide, the lines of care, to include and expand that to include CBAS as part of their marketing to their members, marketing education to their members.
That's a great idea.
Yeah, LA Care just sent out a letter to their physicians, sort of reminding them about CBAS. It was like a full-page article. Some of you may have seen it, which was really, really helpful because that's often the front line, right?
Right. Now, so that's great, Mallory, to think about how the plans can market, we'll put that in quotes, educate both consumers, clients, but also the provider community, the physicians, about the role of CBAS and how to use a CBAS center, because I'm sure many don't even have a connection enough to know how to use a center or what it does. Ed?
This may have been said before, but in a different way, but I think one of the areas of improvement could be to create some flexibility in the model that enables CBAS to be responsive to the particular needs of subgroups within the managed care plan population. For example, people with mental health needs, people with developmental disabilities, people with traumatic brain injury, people who have cognitive impairment, and so forth, because the model as it stands now in terms of its requirements may be overkill in terms of staffing with the wrong type of staffing to meet the needs of particular populations. It's a very rich model, which is wonderful, but to serve certain populations, for example, you may not need to have as rich a OTPT component as you might need to enrich the model with staff to address mental health issues. So I think that would be an area of improvement that may not be related to our immediate goal, but may have to do with our medium or long-range plan.
Really good point. Yesterday I was asked to come visit a residential facility in San Francisco that houses low-income, at-risk of homelessness people with HIV and AIDS, and they live in these facilities for a year to 15 years, average age is 50, and they provide medical services. And they're struggling, and they wanted me to figure out, like, who should they partner up with? And the first thing I said was, you've got to call Molly Steiner and Stepping Stone. And then I went through it in my mind, and I'm like, yeah, they don't qualify for all the criteria. And then, okay, then they should call Unlock, and maybe they should call this place. And who can they partner with? Because they're in the housing business, not in the healthcare business. And so I think, it speaks to that point exactly. Ed, you want to add something, and then John?
Right. Just to illustrate this, there was an article in the news today about the intensive effort to get homeless veterans off the street, many of whom either have mental health issues or have substance use or abuse issues. And so the Obama administration is very focused on this. And it made me think, well, wouldn't an adult day health care setting with staffing and care planning specific to the needs of this population be helpful in a transition plan for an individual from homelessness to long-term residence in permanent housing?
Yeah, exactly. Could you come and help these people? John?
I think we're talking about area of improvement is sort of like definitely thinking about CBAS not as an isolated services, but sitting in the middle of the physician services, all the medical services, as well as sitting in the middle of IHSS services. What are the interactions among and between them, and how the managed care plan can play a role in coordinating that? And I think we heard a lot about care planning, that we don't see a lot of care planning currently because we are so fragmented. Okay? And I think if we think forward into the CCI world, it's very important to think about how the CBAS positions itself in relation to all the other services with residential care facility, with IHSS, different types of population, with regional centers. So it's really how basically that will look like, okay, instead of just, we talk about quite a lot about transition of CBAS and managed care, CBAS and managed care, but really going forward, thinking about improvement, and I think some of that come out is basically that how does a managed care plan allocate a number of days of attendance, which can be a challenging topic. There's no criteria, there's no standards, whether it's a 5-day or 2 days or 7 days or 1 day. These are what we see that is really a challenge. But that challenge cannot be taken care of just between the managed care plan and the CBAS center, but it's really the totality of what the needs of the individual and come up with the most appropriate treatment plan. And so I think the opportunity is that further conversation talking about how do all these different components relate and how this managed care plan will work with the different components to make it happen.
Yeah, thank you. Okay, well, I think you've led us right into the opportunities. We're just going to take a few minutes to really dream a little bit. And all of you are ready for this because this is what you do day in and day out. But I first want to mention to everybody that all the notes from the meeting, including the comments from the stakeholders who are typing in comments, will be part of the summary of this meeting. So when we go back and work at our next meetings, we'll have all of this work and the comments from many members who are not part of the work group but are listening in and actually actively participating with Jeannie and Denise right there. We'll have their comments also built into the summary. So let's just take a few minutes before we look at the STCs and the standards of participation. Yes, ma'am.
So yeah, I'm just going to segue onto what Don was saying, because I think that's the greatest opportunity, really. When you think about, and I think about when we had the Alzheimer's Daycare Resource Center funding component, where there was an extra pot of funding to provide the array of services that somebody with dementia needs. But to the same point, I see a lot of these programs around the state, doing things like specialty programs for people from Czechoslovakia or who are Russian speaking. And that includes staffing, specific staffing needs, language needs, cultural needs, all of those kinds of things. Spanish speaking, Chinese speaking, and I see that in pockets around the state. You know, if there was an incentive for programs to develop a specialty population of people with traumatic brain injury or people with developmental disabilities, we know those folks are going to be getting dementia. Many of the Down syndrome folks will be getting dementia. And depending on where they are and what they can provide, but would there be some extra reimbursement funding for that so that they can afford to invest in such a program and bring in the right staff to get that kind of thing going, because they would be models of excellence. And to me, that's the potential here with this, even if we couldn't do it at every site. We could have pockets of those in places where it would make sense, but we have to address in some way the fact that it takes extra money. To any frail elderly person, if you add cognitive impairment to the equation, changes what you have to do. And I think it's true for many of these populations. So how do we work that in so that we don't, and this is my fear, maybe the flip side of that is my fear. My fear is programs will get to the point where there's no incentive for them to do anything like that because it's too painful, it's too costly, and they can't manage it from a staffing perspective. So they just stop serving those populations. And that would be, you know, the flip side, not so good. But I think many of these folks are very skilled at this. I mean, I see it all over the place, and I think if we could build that in, the opportunities would be fabulous.
Yeah, great. So great place to start. So just think about this, and we're just going to go around the room and ask everybody to
comment, and then we'll ask everybody from the workgroup on the front. If you could wave your magic wand, think about what's the greatest opportunity you see ahead in the future for CBAS. And we've talked about a few things. You know, CBAS is part of the coordinated system of care, an integral part. Incentives to create services for special populations. Flexibility in the model to serve different people with different needs. CCI CalMedi Connect could be a big opportunity. The direct connection through and with the health plans to the physicians. Think about if you were in charge of the world for enough time to make it happen, what's the biggest opportunity ahead for CBAS? So Pam, we'll start with you since you were waving your hand, and then we're going to go around the room. Everybody and everybody else.
I'm looking at it from the perspective of the person that is primarily responsible to integrate LTSS into the plan for LA and San Diego County. And LA is a subcontractor to LA Care and a direct contractor in San Diego. And I'd like to take it out of its silo. Because what I see when I look at this is IHSS, CBAS, MSSP, all these silos. So I would, double underline the flexibility. But I'm looking at, for CBAS, the need for CBAS is if there's no familiar support. So somehow we've got to tie this in with the Family Caregiver Support Program, with the Alzheimer's Association. I'm looking at the whole industry and all the different players and trying to look at how do we best connect all these pieces. Because right now CBAS is in a silo by itself. It's the only LTSS that we're responsible for. So I'm constantly looking at how do we bring these together, how do we create collaborative partnerships where they don't exist today that would drive participation, because we've got the need over here, the family is working or can't provide the support.
Good. Great. Let's get to Beverly and we'll come around the table this way. Let's move quickly, so here we go.
Please speak up.
Yeah, speak up loudly.
Well, I see it as a great opportunity to reduce redundancy of, data collection and to foster quality health outcomes. A good example is like HEDIS measurements. HEDIS measurements involve assessment of ADLs, pain, and medication reconciliation. And we're doing that with our providers that we're not including CBAS. So I think we could become a 5-star provider because quality outcomes both medically and socially. Awesome. Awesome. Yeah.
I think there's a great opportunity for CBAS to be used more effectively, particularly with flexibility in care transitions, skilled nursing to community in particular. And I also think there's a great opportunity for particular CBAS centers to be seen as centers of excellence that could be very supportive to providing integrated care to people living in small board and care facilities, which aren't very staff rich, but could benefit from a close connection with an adult health care center in this community to address the needs of our population.
Yeah, great. Thank you. That's good. Yeah,
So I think the opportunity is that if we can build in the kinds of things that we're talking about here, work out the glitches and build that in. What I see is CBAS becomes the open door to an array of services. They have the folks on the ground to sign people up for managed care, to hook them up with in-home supportive services, to connect them up in the right way with the correct services, and they become the opportunity door that people go through and get connected appropriately. And I think that we could go there, and once those are established, it would be not a simple task, but it would be the opportunity to then say, okay, we're expanding managed care into Fresno. Let's have a program in Fresno, and we build and develop these programs based on demand and population and need where we don't have them and where we've lost them in the past.
Good. Thank you. Okay, we're going to pick up the pace just a little. So, no, don't apologize.
Just talk loud and talk fast.
I'll do my best.
Really deep.
Well, I think the first thing that comes to mind, and I'm relating this back to the term silo, the things described up there are things that we have traditionally done over many years. But we have done them in sort of our own arena, and without necessarily our partners out there understanding that they were actually our partners at all times. We work closely with IHSS and so on and so forth. So really being able to make that clear, the ways in which we can partner together, I think is a tremendous opportunity. And the other, because generally in any room I go into, I help to represent rural. I think looking at really how this model can, as talked about earlier, gain flexibility in order to be able to more effectively serve rural areas, and especially communities where it's otherwise difficult to establish a program like this. And we had a rural model, but regulations were never written around it. So there is some precedent for that.
Yeah, great. Really good one. Tammy?
So I'd like to come back to the care transitions aspect. The way that I would like to see it grow or improve is to be able to use that transition in more short-term situations, because most of the time people consider it long-term, and where I have encountered many cases now that it's somebody that needs to go home with home health, but home health missed this piece of it, or they realized there's two other components there that weren't addressed previously, and now we can really address this holistically in the center and maybe train the care provider. They can coordinate the IHSS supports. They can help train the family, link them up with other services, and it really does become a short-term solution to help their family manage the things that they can effectively manage.
That's right. I think this all keeps going back to this word flexibility in the model. So it's just we're thinking about all of these issues. But a great example and a great kind of piece of the concept. James, anything you want to add?
No, not really.
Okay. No, feel free.
Okay. It just seems like what I've been hearing through all the discussions.
Speak up a little bit.
What I've been hearing through all of these discussions is this common theme of things are fragmented, that the whole purpose is to coordinate care. And it just seems to run through almost every statement that I've seen so far.
Yeah, exactly. Good. Shirley, is there anything you'd like to add about the future?
What is CBAS?
CBAS is your program that you go to at Eschaton.
Oh.
It's a government word for Eschaton. We have we're talking alphabets. Anything you'd like to add about what you'd like to see in the program for yourself or the people that are there with you?
No, it's so nice and good, and I think they do enough for us.
Okay, well, good. Well, you keep thinking about it. If you think of anything, let us know, okay? Thank you. Rosalie, what about you? What do you see would be more supportive to family members?
All of the things that we've been discussing.
Correct.
If we can present these revelations to the powers that be and have them hear and listen and be agreeable to help us make these changes.
Good. Well, you'll be our spokesperson, you and Shirley, so keep listening. We're going to need you. Good point, though. Mark, opportunities.
I see a huge opportunity in the future to utilize CBAS as a care coordination and management, because of the simple fact that we spend much more time with the beneficiary than anybody else. We see these people every day, and we serve them, and we have the data that can be very, very useful in care coordination.
Good. So the hub of the care coordination for those clients. Great.
That's basically what I was going to say, is that we, us as an extension, because they're developing plans of care, they're doing all these assessments, they have their care coordination teams, but there's nobody who's kind of the quarterback, in this process of, that we can identify a lead person based, that's person-centered for that particular client. So keeping that kind of more in a person-centered approach rather than a territorial, siloed approach of how we do approach care coordination through all the systems. Who's the best person who has the greatest ability to do care coordination for that person in the community?
Great. Good. Thank you. Well said. Let's see, Lydia.
I'd like to see opportunities for some experimentation. There used to be, and there is still in statute and regulations, a word called flexibility. Yes. We've been talking a lot about. So if there's an opportunity to be able to experiment, to create some of these models, I'm thinking of our health home model that we're working on right now that really ties together a lot of what we've been discussing with our nurse care coordinators, working in collaboration with the managed care plans and partners. We've been really experimenting with Partnership Health Plan, for example. Sonia's still on the phone around how to have the CBAS Center help the care coordination that's going on in the plan and vice versa. So that would be my wish for an opportunity.
Great. Good. Nina, thank you.
I have lots of ideas. I'm going to just start with health information technology and going back to that sharing of information. So much, we have such an abundance of information that once again can kind of help with those HEDIS measures and just, you know, so that sharing of information. Most of healthcare, we're transitioning now, has been reactionary. And we are really a great tool for diversion to, you know, be preventive in the admission. And I just really think that the super utilizers and the, you know, are not, you would think that we would be seeing referrals right now with the 30-day readmit issues, and we're not. And once again, why is that? Why is that occurring? And I think that that was the primary thing.
Yeah, really good point. Thank you. Michelle.
So I think most things have already been said, but I would just say really to take advantage of CBAS's more frequent conversations and interactions with the enrollees to do some of this more preventative or identifying problems before they get to history.
Good. Early intervention, if you will. Good. John, what do you want to add?
I think many points has been made already. I think, however, I think it's very important that CBAS can be a partner to managed care with a very specific focus. You know that resources are very limited, okay? And I think basically that if you can focus on a population that you can demonstrate that you're actually reducing the hospitalization stage or the nursing home stage, or actually the individual that the plan is interested in discharging from a nursing home back into the community setting, if you position yourself to serve those populations, resources will be freed up to quote-unquote a different kind of payment, different flexibility, different kind of models. Otherwise, basically, there's no resource. If everything is locked up into nursing facility or hospital or IHSS, there's no resources that can be freed up. So I think it's very important that you position yourself as a partner to manage care plan and say, hey, let's take the tough cases. Let's see how we can bring people out. And instead of the outpatient spending $5,000 in the nursing home placement, but nevertheless with CBAS at a high cost to the current payment to CBAS, you can maintain the person and get the person out. That is the most immediate opportunity that I see. Okay? Otherwise, you'll be debating about payments. Okay, where is the payment coming from? Okay, but I think it's the partnership with the managed care plan to say, let's focus on specific population and let's reduce that cost of that population, and that's where the payment will come from.
Good. So let's hear from the people that are on the phone. This is the test of how well people staying power on a telephone meeting. We'll start with Bill Henning. Bill, are you still with us?
Yeah, I am. Thanks.
Yeah, good. Good test. Good friend. Thank you for saying that. How about an opportunity that hasn't been said or one that you want to emphasize?
You know, my pain point here is the funding mechanism. The way it sets, and I could be confused on this, but the way I understand it is at some point in time we are frozen with our funding that is at the current number of members enrolled at an average of 3 days. And so the problem then is that there's sort of a cap on funds available to enroll new members. And my dream would be to just have a, the state at some point, like Oregon does, just say, hey, here's the money. You guys use the money for the best outcomes that you can, and then we have a big incentive to go out and expand CBAS. I think there should be a CBAS in every neighborhood. I'd love to see one on every corner, because I think there's a huge amount of potential there for CBAS, IHSS, MSSP, to keep people out of long-term care and other higher cost centers. But we can't do it the way the funding's set up right now. So I don't know, I don't have a great suggestion on how to do that, but I would go back to the table and look at how to align financial incentives better so that all of us have a financial incentive to use these resources more fully.
That was great, Bill. Everybody around the room is shaking their heads yes. So thank you for adding that. I put it on the improvements list and it's on the opportunities list. Let's see, Mallory, are you still with us?
I'm still with you.
Great. What about you and opportunity?
I know everything everybody says, and Bill, thank you very much. I wanted to say that I want us to be a resource that the community sees us as a go-to place for whenever they have any kind of a vulnerable elderly person or a person with any kind of dementia or a person who has any kind of disability. CBAS is the place they can go to initiate the process for helping those individuals. I'd also like to see us create within this, and this is based on the fact that we're operating on adult day health care regs that are older than Methuselah, that we create a process here that allows us to adjust and change as easily as possible as we develop this new health care system that the Affordable Health Care Act is creating.
Great. Thank you for adding those. Wendy, how about you? Anything else you'd like to add to the opportunities list?
I would, I think the standard is for a lot of CBAS facilities, they finish their day around 2 or 3 in the afternoon. And I know that there's probably staffing constraints and so forth and resources and financial reimbursement. But I would love to see CBAS facilities open longer and maybe even provide weekend services to help families get some respite in caregiving. I mean, you talked about think outside the box and dream what you can dream. I would love to see that.
Great. Great suggestion. Thank you. Sonia, are you still on? Sonia, get off mute. Join the meeting.
I believe Sonia left.
I think Sonia left. So you can help
Sonia left. She did have some points to add, which I don't know if it's visible to those who are there in person, but I could read them aloud.
Can you tell me who's speaking? I don't recognize your voice.
Wendy, actually. Sonia
Wendy?
The HCS meeting, but she wrote down a list of comments. I don't know if that can just be shared on your screen by the organizers, or if you want me just to read them out.
No, we're getting it on the screen. Thank you. Okay, Robert, are you still there?
I am still here, yes.
Awesome. Great. We haven't heard from you.
Well, I'm listening intently and watching the board, and it's really encouraging to see this kind of conversation and creativity and vision quest going on here, and recognizing that there's an enormous future for a program like this. I think if you look at our demographics and the amount of care that's going to be needed in the future and the number of people who are available to give care, these sorts of programs really serve as a solution, I think. And I liked what Dr. Henning said about making sure that resources are available to support a CBAS center or a robust and very fruitful availability of CBAS centers. I do see this as being a very highly needed service in the not too distant future, and probably a way to save a lot of money for the state. If we're looking at these managed care plans taking on these new clients that are higher acuity, have a great deal more risk, I'm wondering if plans are sort of pivoting now to the CBAS Center as a solution for this new class of clients that they have. And that's sort of encouraging. And it seems like the CBAS model is sort of beginning to take place of a geriatrician. You know, it's almost serving, you know, as the geriatric resource for plans. And I think that there's a lot of potential for you know, a center like a CBAS center to solve a lot of the care need problems that exist in our community. So it's very encouraging to see this conversation and hear it being so well supported by DHCS and CDA. And I wanted to say thank you for this.
Thank you. Well, thank all of you for your comments. And again, I want you to sort of keep all this in mind. When you see the notes, it'll come back to life. Because as we start to go through the next part of our agenda, and we're going to move very quickly now, and as we start to do our work at meetings number 2 and number 3, all of this information is going to be key to how you think about changing the STCs and the standards of participation. Because we want to think about the near term, but we also want to keep in mind what's possible in the future. And you all have, I think, a very clear picture. The details have to be worked out, but a clear picture of what's possible. And it seems to be shared between the CBAS centers and the health plans, which was not, I think, where you might have thought this would all have been 2 years ago when the difficulties began and the transition began. So thank you all for your participation. I hope it was worthwhile spending time on this discussion. Now we're going to, let's see if I can make, hey. Now I'm going to turn to Denise, and we're going to quickly review the standards of participation matrix and the special terms and conditions, the STCs, and just talk briefly, very briefly, about what's ahead and what we'd like you to start thinking about as we start to prepare for our next meeting.
Okay, sure, yes, very briefly, because I'm cognizant of the time. We have public comment starting here very soon. I don't want to cut too much into that. So what we did at CDA in sort of preparation for some of the things that come next in this work group's activities is we developed a couple of matrices. And we're going to make those available to you on the work group, and we'll post them on the website after this meeting. And what Bobby has just flipped the slide to right here is just a snapshot of the standards of the special terms and conditions matrix. And this is the tool that we're going to share with all of you and that we're going to begin working with. And so what it includes is a breakdown. The format here, let me just start at the top, and you see it says August 29, 2013. I just want to remind you that the special terms and conditions that are in the 1115 waiver, they have changed a few times along the way. So the numbers for the STCs that have been associated with CBAS have changed. So if you didn't know that, I just want to make you aware of that. August 29th is the latest revision, and it did move all of our STC numbers. Okay, it didn't change anything qualitatively, but it did move the numbers. So the link to the current 1115 waiver is on the CDA website under Stakeholders. You can just click on it. It'll take you right to the current version, the whole waiver. But the CBAS particular waiver conditions are beginning with number 95 there. And then I would just say, for the purposes of this work group, it's probably easiest just to look at this matrix, and you don't have to look any further because we've just taken them and put them in these boxes. So we've broken them down into reasonable bites. If you look down the left-hand column there where there's the number in that pink or orangish colored header row, if there's a number sign, and then there's a number that we've just given to each of these main sections. So that will help us when we divide these up and we start studying them. And then terms and conditions, then we have the exact text in that second column there, and then they're broken out in a way that we think makes sense and in small bites. Then we have recommended actions, and this is where we're going to be as a work group. We're going to be moving through making recommendations to either delete it, to add something, to change something, or we're going to say we think there's no change. Then there's an amendments or a comments or questions field there that you can we can write in and put various things that will help us think about things as we go. So that's the document format, and then and I'll move to the next one just quickly here. We have a similar one for the standards of participation, And again, same format where we're going to be looking at what's in the standards of participation. And what I want to do, if I could just briefly, in case anybody missed, how this whole thing works and how everything interacts here. First of all, there's a date on the top of this document. December 2011 is when the standards of participation were agreed upon. And for those of you who didn't have the pleasure of being involved, these standards of participation were a collaborative effort between DHCS, CDA, and CBAS ADHC providers at the time. And that was a result of settlement agreements. And so this effort was jointly entered into with all of us to develop the standards. Now, the standards of participation are just referenced in the waiver. So the 1115 waiver, CBAS, STCs, reference the standards of participation, SOPs, and what it says essentially in the waiver is that the state shall not change the standards of participation without getting approval from CMS. Okay, so the standards of participation are basically incorporated into the waiver by reference. So when we talk about the immediate tasks that Bobby talked about earlier, that we're going to be engaging in meetings 2 and 3, January and February, we're talking about working on the STCs and the SOPs, Special Terms and Conditions, Standards of Participation. Okay, so the same kind of format applies here. And again, sometimes the breakdowns weren't that tidy. Sometimes the sections are real clear. This was a section on facilities. This was a section on eligibility or program services. But a lot of times they're not. So we've kind of broken them down into chunks in ways that we think we can work with them within this work group. If you would flip the slide, one more slide, and this is just an example. You can't see sample really well on this slide, but it does say sample on it. And what essentially what this is just an example of how we're actually going to build this thing out. We're going to say on this one we're looking at it's 95C in the Special Terms and Conditions, and we're saying this one has to do with transition-related activities. And so, again, this is just a theoretical exercise saying, okay, we're going to say delete this one. And if you look over in the comments field, it says, provision is related to transition of ADHD participants into CBAS at time of ADHD Medi-Cal benefit elimination, no longer relevant. Okay, so again, just an example of how to think about how we're going to be looking at these STCs. The second one, we made a check there and said, theoretically, again, delete. And then, again, they're related to the transition, but we put a question out here saying, second level review is not specified elsewhere in the STCs. Should second level review requirements continue for new CBAS participants after 814? If so, where should they be specified? Again, a theoretical exercise just to show you how we're going to be working with these documents and making comments, and it's all set up to, I think, what we're going to talk about in the way of assignments coming up. So, so part of what we talked about before the meeting, and I'll let Bobby go into a little bit greater detail, is that we're going to look to getting into smaller groups so that we can have a few people who are responsible after this meeting for studying certain STCs and SOPs and coming back to the January meeting sort of prepared to share what it is they concluded in their conversations, what kinds of recommendations they might want to be making, and then reporting out to the group as we march through these exercises. We weren't prepared to make any kind of assignments today. In fact, as we got into looking at these STCs and SOPs and seeing how they all overlap and interact, it got very challenging for us to think about how we wanted to divide them up. So I think we wanted to have a conversation with all of you today, and then go back to the drawing board this week, and then get back to the work group about how we want to divide things up for next time. Does that capture it, Bobby?
Yeah, that was great. So let me just stop, before we talk about the homework, let me just ask if anybody has any questions about the setup of the STCs, this grid or matrix, and the standards of participation. What we're trying to encourage, and if you have a suggestion of how to set the matrix up differently, please offer it. What we're trying to encourage is really a worksheet where you will be able, with some of your colleagues here and individually, go through the STCs and the standards of participation and identify, should this be deleted? Should something be added to it? How should it change? No change. And then the comments. Anybody have any suggestions or questions about the setup of the matrix? It's not set in bold, so you've got a great idea. We'll love it. Ruth and then Lydia.
Well, mine wasn't about how it's set up. I think that's perfect. I guess my question is are there any of these standards that you just can't change, absolutely, because of Medi-Cal reimbursement standards or because of other standards. There are pieces of this that we just are not going to touch on, and that's fine. I just wondered.
Yeah, that's a great question. Denise, do you want to comment on that?
Well, I'm going to look to John and Jean for some help on this, but I think that there are some things clearly that we need to be mindful of that CMS may want us to keep in because they're part of what they originally approved and sort of negotiated with us originally. But as far as anything that's absolutely out of bounds, I don't know that I've seen anything as I've looked through.
No, I don't see there's anything that is basically off limit. But the question is, what do we want to change and how do we change it to? And whether when we change it, would that constrain the future or flexibility, or will we actually create more structures and strictures that we don't want in the future? So I think we have to be mindful of that, but I think it's important that everybody is familiar with the SCC and SOP and go through those kind of items together, and then we have a better product at the end of the day.
Yes, Lydia.
So I have two questions for clarification, and one just John reminded me of, which is, so I'm glad you raised this, Ruth. I've asked this before, I don't think I've gotten an answer, sort of what's the hierarchy of controls from legislation, so statute, regulations, waiver, SOPs, et cetera, and what prevails? Because I think there are some things in these SCTs that are in regulation today. So they're almost like, if legislation regulation prevails, then it would be good to call those out so we know we don't have to spend time on them, or we spend time on them, but we know we need to have a change in law to make it happen if there was consensus. So that would be helpful. And then the second thing is, and this is more of a question of process because I've never been involved in this particular process, this directly, is at what point does CMS get engaged, and are they invited to these meetings so they can kind of learn and have the benefit of the discussion and conversation? Because kind of coming in cold afterwards, it seems like you're going to be rehashing a whole lot of stuff that would be maybe helpful ahead of time. So that's just a question. I have no opinion one way or the other, except I think it would be helpful as a process to have more people involved who are decision makers at the end of the day. And I'm assuming, since it says recommended, that this group is going to try to arrive at a consensus around a recommended action, but at the end of the process, it's really DHCS and CMS that make the final decision, right? Just so nobody is disabused of any power that this group may have.
So let's tackle the first question first. And we have John and Laura and Ed, and we also have Michelle and Robert, for them to add in anything that they'd like in terms of the hierarchy and what takes precedent.
I think in terms of many of the CBAS standard participation's reference to adult daycare center regulation in California. And so those regulations need to be reviewed and need to be changed. Okay, so in order to make the CBAS operate, and those changes tend to be at the state level, whereas from the 1115 waiver, it's really a CMS Department of Health Services agreement to share the costs of the CBAS services. Okay, so it's really, one is the financing side, one is definitely more the state-to-state regulation in terms of protecting the consumers and stuff like that. And the question is, how do those two things mesh? Okay, I think the CMS involvement in the past 1115 process is quite intense because CMS also hears from the advocates, and it's also hear about the settlement agreements and so they hear from many sides of the story, and so they are very actively engaged in this 1115 process. So whatever this group come up with, whatever we take as an input, we will definitely work with CBA to come up with the STC and submit to CMS, and CMS will definitely have their input, and that will become the final product. Okay? But that is probably really more about financing. Okay? More about 50% state, 50% federal government, the federal government willing to pay the other 50%, and so on and so forth. really the flexibility we talk about, the Ed talk about, tend to be more in the state regulations. Okay, so if CBAS doesn't have the adult day health center licensing and all the regulations related to adult day health center as a base, what would that base be? Okay, it doesn't exist. There's no definition of CBAS without referencing to adult day health care center. And so I think that tends to be probably more a state issue than a financing issue, and that's my perspective. Laura?
So John, to piggyback on what you're saying, if we're identifying things through this process that would involve a state statutory change or regulatory change, it necessarily then becomes a mid or long range sort of adjustment to the program because of what's involved in doing statutory and regulatory change within the state of California. And in the short term, if it doesn't involve that, then fine. If it's a recommendation that, comes from the group and is agreeable to DHCS and CMS.
Can I add on to what Ed's saying, though? One context, I think, for the setting of these standards of participation where much of the program rules are. So a lot of the program rules are not in the special terms and conditions. But the SOPs, the standards of participation, we incorporated by reference, as you know, all of the ADHC laws and regulations. Part of that was expediency at the time of the settlement agreement and moving forward with the waiver. This was an effort, I think, on our part to keep the change as minimal as possible, keep the program intact as much as possible. So we incorporated them all. There's nothing, as far as I would see, to prohibit us from saying we don't want to incorporate certain laws or regulations by reference, or that we want to have different standards of participation that are in addition to those already cited in that. So I think there is some flexibility in how we define the model and the program rules within the standards of participation, but there still is no CBAS that's defined in statute. It's all by reference to ADHC. I just wanted to make sure that
Laura, would you like to add something to enlighten us?
I think I would concur with my colleagues in terms of waivers and then kind of how things flow. In architecture, its form follows function. In public health, in public policy, its form follows funding. So certainly the waiver, I certainly see as the first step in the process. Then to the degree that there need to be statutory changes, that would follow. Usually there are bridge opportunities for making that happen until kind of the next session. And then we have certainly acknowledged that we need reg cleanup, but we just have felt that we needed for the program to transition and land and get established before we really looked at that whole process. So that's my thought, and I think we're all on the same page with that. The process that, in terms of discussions with CMS, I think Lydia, you brought it up, those, at least from our experience with DHCS, tend to be rather, they like to have it focused on the product before them or under consideration. Their conference calls, they're very structured and back and forth with their questions about particular provisions and further consideration, and we'll be back to you in a certain period of time. It's a, maybe they would like to be involved earlier on, but the engagement usually tends to be pretty focused and time limited and formal. That's my experience. John, I don't know if you have other thoughts.
And we did invite them, by the way, to the stakeholder meeting.
Lydia, just as an example, when we did the original version of not the CBAS part, but the bigger waiver, where we had 6 technical workers in a big stakeholder process that went on for months and months, CMS was not present ever in the early formation. Later. Diane.
I just wanted to add as a sort of a reminder for those who don't live with the program every day that we're licensed adult day health care programs. So as we look at everything, we probably want to keep in mind compatibility with our licensing standards as well, which won't go away because we have to be one to be CBAS.
And that piggybacks some of what I was saying. Meeting more.
Is there any way, and I realize, I'm sorry, is there any way, and again, I'm not well versed in all the regulatory pieces of this, and I apologize for that. Is there a way to mark some of those or put a star by them or something so we don't spend hours and hours and hours on something that turns into a very long-term process, and we might do more to work hard on some of the things that we can really enact and change quickly and know that they'll probably go through?
Yes, we can do that.
That's a great
On the matrix, I'm sure we can.
Yeah, I get it. Not to create work for you.
No, that's a good suggestion. So let me explain what I hope we'll be able to do. And as we get into this, we may have to tweak this a little. But the next two meetings, I recommend as much caffeine as possible. Or whatever it takes to stay focused.
I like red
Because our goal really is you are the experts in how the programs run, what makes them tick. The health plans are here because of their role in supporting and financing these efforts. And literally, our hope is to go through these STCs and the standards of participation literally one by one and fill in the matrix and discuss the important issues. So here's how we suggest we do this. First of all, I would recommend that every single person on the work group read through all of these. Some of you were involved in writing them. Refresh your memories if you read them already. Everybody should read through them. It's not, what you should be reading at 10 o'clock at night. Start early. It's a little boring. Start out or tedious. Sorry. Then what we're going to do, if it's okay with all of you, is we're going to assign small groups of 2, 3 people, a health plan rep, a provider, and an advocate, to work together on a group of the SDCs or the standards of participation. Originally, what we had hoped to do was to clump them in better categories so that you could focus in on eligibility criteria or you could focus on facility requirements. It's really hard to do the way the SDCs and the SOPs are written. So what we've decided to do is let's just pick 3 of us, and we'll send you an email, and everybody will see it, and we'll say Mark and Celine and James will be responsible for 1 through 30 STCs. And we want you to review them, fill in the grid, have a conference call before our next meeting, talk through your ideas. And the next group of 3 will be responsible for 31 through 60. And so you'll become expert in that small group. And now some of them, of course, relate to things in the standards of participation and vice versa, or to SDCs later on. And that's why reviewing them in advance, the whole group, is helpful. Then when we come back together, probably the first half an hour or so of the next meeting, we'll have you work in your small group just to get clear on your ideas and your recommendations. And then we're literally going to plow through them, which is why you'll need fortification. And as we plow through them, we're going to want to have, some of them are very important to discuss. And some of them will be just, keep going. But there's probably quite a few that we really want to have an in-depth conversation about. We may want to scratch our heads about, and we may want to come back to, because there's other SDCs that are relevant. So that's our hope for the process for meetings 2 and 3. We won't get it all done in one meeting. But we want you to do your homework before meeting number 2, because I think it will help move the process along. Does that make sense?
Yeah, it does. My thought as you were talking is that, it may be helpful if we had color coding of some kind. Okay. Okay. Yeah, okay.
some sense of ones that were similar in some other category. So we'll give you instructions. It'll be like taking the SAT test, or not the MBTI, some involved test. We'll give you directions. We're going to assign you a partner, or 1 or 2 people, probably people you don't know, because we're going to try to mix up the state. We don't necessarily want the LA folks working together. We want you to get to know the other people in the group, because in order to have a meaningful conversation, everybody's got to dig right in and roll up their sleeves. So once again, it would be most helpful at meetings 2 and 3 to have as many people here in the room as possible. Obviously, we'll make it work with folks that can't get here physically, but it would be great if you could look at your calendar and try to figure out how to meet. So anybody on the work group, because now we're going to go into, we have a few comments from the stakeholders that we want to review. Then we're going to go into public comment, because I don't want to shortchange that. Just want to see, does that make sense to everybody? And if anybody has a different idea or a different way to do this, we are totally open to your suggestions.
Not directly related to that, the only thing that's on my mind right now is I keep thinking that it would be helpful at some point, in order to better understand how all this fits together, to have an opportunity to have some kind of cross-sharing of what our worlds look like. Looking at some specific situations that we're dealing with in our centers today that relate to how we're doing these things today, understanding how the care management is taking place at the management care level. At least to have some time to do that, I think would help us to understand better how to fit those worlds together in terms of the next set of documents.
That's a really good point. And maybe, at least for preliminary, that can happen in your little, we call 3 together, triad. Because in each triad will be a provider, a health plan, and an advocate, or other interested work group member. So that might be the first place to do that, and then we can think about how to weave that into the conversation. It's a very good point. Anybody else? Okay, so your homework as of this minute is to either download them, as I have, or
tomorrow.
yeah, and they're on the website already.
Oh, they are?
Yeah, they're on the website.
The matrices?
Yeah, I'm sure I downloaded. Okay. Well, they'll be on the website tomorrow. I'll start reading them. Just, obviously don't commit them to memory. They're going to change. And then you'll get your assignment probably no later than Monday. You'll get your assignment. You'll get the new version of the matrix with the regulations identified and any other kind of enhancements, plus a set of instructions about what to do. So please commit in advance to connecting with your colleagues who you're assigned with, and don't call and ask if you can change because you want to be with your best friend. We need you to just get to work. Okay, so we have just a couple of comments that I want Jeannie to talk about in terms of how the staff at DHCS and CBA are organizing stakeholder input. And just a few comments on the input that we received before today's meeting. We've received tons during the meeting that we'll incorporate. You want to take it, or Barb? I can take it. Say that today.
You want to know about the general?
Yeah, sort of what we've heard already.
We're going to continue getting input on our website, our email address at DHCS, which is cbas@dhcs.ca.gov. And CBA also has the primary website for collecting input from any of the participants out there that want to share any of the
address. Yeah. And put it up here.
It's at the very end of the slide.
Oh, sorry.
So it's the last slide in the
second to last slide. Here we go. Here's the, is this the one we want to?
Yep, yep.
Okay. This is the website address for the public that are listening, any stakeholders listening, and for the work group, if you want to provide comment. You want to just comment on what we've heard so far, not today, but before today, the kind of comments you've gotten, how many?
Sure, I can just real quick. We have a log that we're keeping here at CBA, and whether it comes in through Jeannie's mailbox over at the HCS or comes over here, Jeannie and I talk 10 times a day. We are keeping the log, and it basically includes when something was submitted, how it was submitted via email, via the phone. We track things on our database. We don't miss a thing, so we want to make sure that everybody knows that the operators are standing by. We collect what the subject is, what the general input or question is, who submitted it, whether there was follow-up needed, and we're basically grouping these things. And not surprisingly, most of the comments we've had so far, a little bit different from what I've seen coming in today, but most of the input we've had today had so far had to do with sort of clarification of the stakeholder process and how it was going to unfold, clarification regarding program rules, some input regarding rates, the eligibility, the face-to-face processes, a lot of the things that we're going to walk through as we go through the SPCs and the SOPs. So we've had a lot of feedback on that nonprofit provider issue that's in the standards of participation. But so far we've heard from 24 individuals. Again, we're keeping the log, and we'll just work on making sure that we get all that feedback to everybody.
And then at every meeting, in the beginning of the meeting, we'll get a summary of the comments and what the issues are.
And just so you know, most of those we handled during the last session that we had on October 23rd at the kickoff.
So just 1 minute on what have you been hearing from people today? What's been the volume of comments, other than the sound?
The sound was by far the highest.
That's good.
We have
fix that.
The nonprofit requirement for CBAS centers. Other ones were just input when you guys were talking about, face-to-face assessments, and some of it is how best to work with the managed care plans.
Right. Were there lots of comments? A lot of people
Lots of comments.
Great. That's wonderful.
Several people sort of applauding for various people when they said things. Some people actually asking us to dole out hugs based on people.
Please send us compliments to the board members.
And also wanting the rural counties are still wanting to know when CBAS will roll out as a benefit. So kind of across the board, but different times when you're talking, different comments were coming in.
Great. So it's been very interactive. Yeah. And I know Jeannie's been writing back to people as we went, so they haven't just been falling into a big hole there. So thank you, members of the community, for providing that feedback. So I'm going to stop now, and we're going to stop and spend some time hearing from stakeholders who are not part of the work group. We call them the public, but they are stakeholders. They're not members of the work group for any number of different reasons. Most importantly, because we have to have a smaller group than all the hundreds of people who are interested in this issue. So what we'd like to do is we'd like to ask members of the public that are here in the room who want to make a comment to just come forward to this microphone here. And if you have a comment to make, and state your name and your organization if you're affiliated, and take 1 minute to offer your comment, and then we'll take some of the comments, if we have time, that have been sent in through the web for people on the telephone. So this is an important time because it's an opportunity to hear from people who are not on the work group, but who have a lot of information and knowledge about the program and about what they would like to see themselves for the future. So any members of the public that are here in the room, if you could just come up to the front, we'll take you one at a time. We'd just like you to talk into this microphone here. Well, please come and make a comment. You can just stand right where I was standing right there. That way, that's little black thing. That way people on the phone can hear you.
Good afternoon. I'm Nina Weiler-Harwell with AARP California. So first of all, I really appreciated the conversation today and some of the promises about CBAS and the CCI to eventually get us to a more coordinated system of care that we've been talking about for, well, as long as I've been doing this, which is 15 years. The question I had was stakeholder input. So we send in our comments. How will that be incorporated into the work group's final recommendations? I mean, it's nice to send in comments, but are they going to be taken really seriously? So I'd like to hear about that process.
Thank you.
So you want to respond?
Yeah, I think
sure.
that's an important question.
Okay, so one of the main reasons why I didn't go through each of the individual comments today, besides time and wanting to hear what's happening here today, but also most of the comments came in during our last discussion on the 23rd, and so we addressed those during our kickoff webinar session. So most of those issues, if people were participating, they got to hear them. So I think that what we anticipate, and again, I can roll these up any way the work group wants us to provide the feedback to them, but what we were anticipating was before the next meeting, we'll have the main subject areas sort of captured and summarized, and specific feedback shared with you. So as we walk through the STCs, what I would envision is, Nina, is that these are going to be relating to some of the things that we're actually talking about in here with regards to the STCs and SOPs. So does that answer your question?
So again, at every meeting, you'll get a list in these categories for you to look at as you're working through the STCs and the SOPs. So you'll have your own notes and your own thoughts, your committee's thoughts. You'll have the notes from the last meetings, and you'll have the feedback provided by the public, or the other stakeholders, so that it can be incorporated in.
So that reminded me that, as we've done with other waiver-related activities, that it seems like people who aren't officially on the work group could also use the same matrix that's going to be on the website tomorrow, and just even write comments related to those specific, and that would make it easier for the state staff to compile everything, but I think it would help kind of give an organization through what we're doing. I just thought of that as you were responding.
That's a great suggestion. So for the people on the phone, it was just suggested by one of the work group members that other stakeholders who are not on the work group who would like to make comments on the STCs and the SOPs should feel free, in fact, feel empowered to use the matrix themselves and send in their comments on the matrix, and then that can be shared. Those comments can be shared in an organized fashion. That's great. That's a great idea. Thank you, Nina, for your comment. Any other comments from people here at the meeting? Okay. How about public? How about comments from stakeholders who are on the telephone and are typing in on the webinar format? And I'm going to look to Jeannie and Denise to read their comments.
One comment, could we get a list of who is on the work group?
The list of the work group members is currently posted on the CBAS. I'm going back to the on the CBAS Department of Aging webpage, and that will be updated because we have a few changes in attendance, and some people sent substitutes, so we'll update that. But it's already there, and it's in the PowerPoint slides that we were working with today. I think it's slide number 4, has the list of the members and their affiliations. Good question.
Okay, next was a comment. I'd like to say how pleased I am with the process so far. Oops, and I'm glad to hear. Sorry, it was a good one. G just lost it. Sometimes it jumps. Sorry. Here you go.
Jeannie, also you need to speak up a little bit. I'll let Denise.
Yeah, Denise can. I have a voice. I'd like to say how pleased I am with this process so far. I'm glad to hear so much input from those outside the work group, and the fact that our input will be included to the work group.
Thank you. Thank you for that comment.
I think the people who are on the phone should also have the opportunity to call in and make comments, not just those who are in the room. We also had a comment that they were hopeful that we would have one of the stakeholder meetings in Los Angeles. And
Nonprofit. What was the one about nonprofit? Just in case. Nonprofit comment. For those people that are on the phone, the silence is the sorting of comments, and not a technical problem. So just be patient for another 10. Oh.
Yeah, it was just the nonprofit requirement for CBAS that hasn't been broached yet. So that's in the standards of participation, and that will be undoubtedly part of next week's discussion. That's not.
So in case you didn't hear that, the comment was the nonprofit status for CBAS participation hasn't been broached yet. It is one of the standards of participation issues and will be discussed when we go through the standards of participation.
Oh, there should be a unified web page where we can check the TAR status. Let's say health plan page. Choose the plan provider, check the TAR status. For now, it is working only for Care First plan.
That's right. That person to say
Any others? Nina and others have touched on key points around the fragmentation that exists. As a result, CBAS and other programs and services are not utilized to their full potential. The goal of CCI is to close these gaps. Unfortunately, the fragmentation will continue if beneficiaries are encouraged to opt out and remain fee-for-service. This work group certainly is the right start for a functional and coordinated path to a comprehensive psychosocial medical model. Thank you. If regulations go away, is there any opportunity to use the center's plan of operation as a way to determine if there are meeting care needs as they state they would? Question mark. And when you talk about flexibility in the model, we operate an activity center for DD adults with nursing component for caring for DD persons with health care problems, which would normally exclude them from attending an adult day health program due to restrictive conditions. The cost of the program is about the same as an ADHD CBAS program, but instead of many professions, we provide nursing at a high staff, consumer ration of 1 to 3. We also provide social support and a rich activity program that meets individual needs.
Okay, let's take one more.
Some of them are adding to previous statements.
Something like what Mark said about a common assessment tool.
They also wanted to know if there's been any collection on information on the validity and reliability of the current use for the face-to-face.
Okay, I think that's great. I mean, great comments, and again, they'll all be cataloged, and we'll see them all as part of our next meeting. So I just want to ask again if there's anyone here from the public who would like to make public comment before we move to the end of the meeting. I'll make a public comment. Okay, you're allowed. Please come forward, madam.
This is Laura Conley, and I would just say I know there are a number of you who are on this work group who are also on our universal assessment work group and our broader CCI outreach and implementation efforts. And I think a number of these issues are certainly crossover issues, which I think is wonderful. I really thought that the tone and the discussion today, the collaborative kind of nature of the input was very, very positive, and I'm really heartened, as I think a number of other folks have mentioned, in just that dialogue. I think it sets a really great stage for our moving forward in terms of this work group's efforts. But I was just noting, just in some of the areas and comments that people made in terms of both what's working and what needs improvement, some of those don't just apply to CBAS. Right. There are other issues that we need to look at, and so I'm certainly locking those away for our continued discussion. So thank you very, very much. I think it's a fruitful discussion, and really, really do appreciate all of the time that you've put into this, and your passion for this. Really, it shows. And thank you, Bob.
Yes. Thank you.
Anytime. And we'll get the lights working better, as Bobby said, by the next time.
So, thank you, Laura. So I just want to review the next steps and what we have ahead of us, and then we will adjourn the meeting. So I have 3 next steps, and I'm sure Denise and Julie will add more. First of all, there'll be a summary written of the meeting. That will include all of the discussion that we had and all of the conversation. We will update the list of the work group members, and that will be made available both on the website but also sent out to the work group members with email addresses so that you can contact your colleagues that are going to be in your small group. We will not post on the web your email addresses. We will post your names and your organizational affiliation. That's what it is. And by no later than Monday, we will send out your homework assignment. So again, you'll be assigned to 2 new best friends for the next 3 months who you will work with on your group of either SOPs or SOPs. After the meeting, if anyone has any, you go home and you think about this in the shower tomorrow, and you have any ideas about how to improve the homework assignment, please contact me or Denise or Jeannie or Ed or John or Laura, and let us know so we can still revise our approach somewhat if anybody has any ideas. And I would say fourthly, if anybody has any feedback on the pace of the meeting, the content of the meeting, the facilitation of the meeting, anything other than the staff, which we're going to fix, I would certainly love your feedback. And don't hesitate to email me or call me, or again, Jeannie or Denise, and give us any suggestions for how to improve the meeting. This is your meeting, and we really want to make you feel like you're having plenty of time to say what's on your mind. Any other next steps?
I have a couple for us. We're going to identify some of the issues in the matrices that have laws and regs implications, and then we'll post those. Also, just so you know, we've also set it up so it's cross-referencing, where standards of participation cross-reference STC, so we'll have all those ID'd too. And then we're going to catalog all the feedback that we've gotten to date, and we'll share that.
Yeah, are you going to color code?
I just had a question and a suggestion. Right. If there are any other materials related to the STCs that we may not be aware of, something that's gone to CMS, like around monitoring, access, provider payments, I'm just kind of glancing through the STCs right now. That might be helpful for us to have on the website too, so we can take a look at what analyses have already been done or provided to CMS. I know I thought the April quarterly report, but I'm sure there have been others. Yeah, and I only have one, and I don't know that they're on the website.
This would be helpful.
And then, I don't think we've done any work yet collectively on the quality improvement. So, the people that are looking at quality, if there's anything that's been issued around that already, would be good to know. So just, I'm thinking of any other reference materials, or if nothing's been done, then we should know, well, nothing's been done, so that's something we have to really talk about. So that would just be a suggestion.
Great suggestion.
anybody has any materials that they think should be posted, that would be helpful to the worker, send them in, and to Denise Regina, who get them posted, so other members of the worker can see them. Okay, anything else? Any other assignments that you worker members have for us? I'd also like to call out the CBA staff who you've seen in action, Ryan and Adam and Barb and Karen and Carol and Pollyanna, who's starting around with my kids. They did an awesome job responding and helping and supporting us. So thank you all very much. And the meeting is adjourned. So thank you for coming.
Thank you, everybody.
5 minutes.
Yeah.